Jasmine Lucero Lopez, presenting on a virtual platform to mitigate the effects of isolation among older people living with HIV. So thank you and enjoy the presentations.
Hi, everyone. My name is Jasmine, and I'll be talking about our study. Sorry, I'm losing my voice, which was the implementation of a virtual platform to mitigate the effects of isolation among older people living with HIV. And we will discuss our lessons learned on the usability of the host platform, Discord, based on the feedback from our community advisory board. Next slide, please. So you may wonder, why did we want to focus on older people living with HIV? Well, it's important to consider that older people, in our case classified as 50 years old or older, face unique health challenges since they're a particularly vulnerable population. And as all of us know, during the pandemic, social isolation has exacerbated depression and anxiety. To mitigate this impact, we created this virtual village, and it's meant to connect older people living with HIV to one another, to provide regional resources, and to connect them with experts to answer any health questions or just questions on a given topic of their expertise. And so Discord had the most compatibility to implement these desired functions. So we created a server through this platform. And for the purpose of this pilot server, we had 13 community advisory board members, also referred to as a CAB, test out the Discord server for the span of 3 months. And their aim was to evaluate the usability of the platform for this project. Next slide, please. So our CAB is composed of 24 older people living with HIV, and out of this group, 13 volunteered to test out the virtual village. And out of these 13 volunteers, there were 6 from Palm Springs, 4 from Los Angeles, and 3 from Tampa. Next slide, please. So first we invited the members to the new server, and then they were supposed to review the functionality and usability of the server over the span of 3 months. And at the end of the 3 months, the CAB members were asked to provide feedback through either written responses or through discussion. Next slide, please. So our results reflected that there were nearly equal amounts of satisfaction, neutrality, and dissatisfaction with the overall platform. And although there were no overwhelming consensus regarding the satisfaction with the platform, there was a slightly higher percentage that rated being satisfied, which was 34% compared to 33 neutral and 33 unsatisfied. Next slide, please. As for usability, many participants reported that the platform was easy and comfortable to use, and they did believe that there was a potential to become productive quickly through using the virtual village on the platform Discord. But on the other hand, many reported being unsatisfied with error messages. An example of an error message in this case would be you create an invitation link to join the server, and it expires after 7 days of creating it. And if you click on the link past this time, it won't allow you to join the server, and the moderator will have to create a new link. But many members did not believe these messages were clear, so this resulted in some onboarding issues. Additionally, many members did not really like the interface of Discord. Next slide, please. So when we asked them, how can we improve? Around half of them asked for further explanation on how to use technology in general, not just Discord, because they believe that if they understood new technology, then they should enjoy using Discord more since it's a new site that they're not well acquainted with. They also requested for us to mirror the interface of Facebook, and it was frequently requested to remove what we call bots. And the purpose of these bots were to complete automated tasks and assist the moderator when they were not online. But many people were uncomfortable with the thought of having bots on the server because they thought they were collecting data or there were privacy issues associated with them being there. And lastly, it was mentioned that we should incorporate discussion prompts that were facilitated by the research team. Next slide, please. So based on the feedback, we learned 3 key lessons. So I would say to recruit a variety of users with differing levels of technological literacy to determine if the usability of the platform was actually what we expect it to be or subpar. And deferring levels can also tell if it's applicable in real life settings. Yes, so another lesson, I would say limit bot involvement, since that was like one of the biggest complaints that we had. And because excessive details about administrator roles in bots tend to confuse participants, which possibly influence reported levels of satisfaction. And then incorporate facilitator guided discussion prompts among users, such as topic of the day or similar types of discussions. Next slide, please. So it is important to recognize that a CAB is necessary to get insight from the community, and they're able to provide the best advice on how to move forward with your studies if you're trying to understand what the desired population really wants from a virtual village or whatever your topic may be. And as for the results, there were no overwhelming opinion, but there were slightly more positive experiences. And upon further evaluation, I noticed that most negative experiences were associated with privacy concerns, which were reflected by the desire to remove bots. And there were also platform biases. Many people wanted to transition to Facebook or other platforms they are better acquainted with. And it's important to note that in spite of negative experiences being reported, the majority of the members agreed that there was a potential to assist socially isolated older people living with HIV. Next slide, please. So I would strongly suggest that future studies continue to utilize community-based approaches through using a CAB, and perhaps investigate platform biases further and other factors that may have not been considered to be inhibitory components to negative experiences or their experience overall. And the reason why I say this is because it seemed that there was a reoccurring request for us to use Facebook, even though we informed them that there were greater security risks. In regard to limitations, I would consider our sample size to be fairly small and primarily male, which is not representative of the entire population. And lastly, members joined at different dates. So what I mean by this is that there were some people testing out for the entire 3-month span. Meanwhile, others joined at 1 month or 2 months. And I noticed that people who joined later in the study tend to have more positive feedback, but we're not quite certain why that may be. Next slide, please. And thank you all. Here is my email and a QR code to my LinkedIn, which you could scan on your camera from your phone. Does anyone have any questions?
Thank you so much. We're going to wait till the end to do the questions.
My bad, yeah, sorry.
No problem, but thank you for a wonderful conversation, discussion, and I look forward to more. So after all the presentations. So now we'll have the next presentation, which is by Katherine Lewis. And I have moments where I am down, but it has made me resilient, mental health strengths among youth at risk for and living with HIV. So thank you very much.
Hi, everybody. My name is Katherine Lewis, and I'll be presenting the results of a qualitative analysis project, which, as was just read, is titled, I have moments where I'm down, but it has made me resilient, mental health strengths among youth at risk for and living with HIV. Next slide, please. So strengths-based approaches are increasingly recognized as powerful tools to leverage youth strengths for a variety of health outcomes, including mental health promotion and HIV risk reduction, particularly for groups which are highly stigmatized. And Ferguson-Zimmerman's resilience framework distinguishes between intrapersonal resilience assets, such as self-acceptance, and external resilience resources, such as social support. So this resilience framework was used as a guiding lens for the analysis that I'll be presenting today. And the overall objective of this analysis was to examine how youth at risk for and living with HIV identify and describe their own strengths related to their mental health. Next slide, please. So youth at risk for and living with HIV, ages 12 to 24 in Los Angeles and New Orleans, were enrolled in a network of 3 HIV prevention and treatment continuum studies through Adolescent Trials Network, which examined the efficacy and cost effectiveness of texting, online peer support, and strengths-based coaching for primary HIV risk reduction or viral suppression outcomes, with secondary outcomes for mental health, substance use, and housing and economic security. Youth at risk were defined as LGBTQ+ youth, those using PrEP or PEP, or those who met the criteria of an algorithm based on lifetime experiences of homelessness, incarceration, probation, mental health hospitalization, substance abuse treatment, recent sexual risk behaviors, or recent illicit drug use. So depending on protocol, participants were randomized to or offered a strengths-based coaching intervention, and those who participated in coaching completed a semi-structured, open-ended strengths assessment that was administered by the coach at the first session. So coaches' notes on participants' responses to the strengths assessment questions were analyzed using qualitative analysis and thematic coding in Deduce, with a focus on self-identified mental health strengths. And in total, 257 youth completed the strengths assessment. So this is a very large qualitative data set that was analyzed. Next slide, please. So in line with Ferguson-Zimmerman's conceptualization of adolescent resilience, participants described both intrapersonal resilience assets and external resilience resources. In total, 6 themes and 2 child themes emerged from the data. And within resilience assets, these themes included protective traits, stress management activities, feeling positive despite current mental health challenges, and no current mental health problems. Within resilience resources, these themes included social or emotional support and engaging in mental health care, which included 2 child themes, therapy or counseling, and medication use. Next slide, please. So within intrapersonal resilience assets, participants described protective traits, characteristics, and tendencies, such as self-awareness, resilience, optimism, and being self-confident as mental health strengths. This is highlighted in the selected quote, which reads, "I don't allow it to get to a bad point. Realistically, I have moments where I'm down, but it has made me resilient and I'm able to bounce back." Many participants also discussed activities or actions to help manage stress, which included leisure activities such as journaling or watching TV, as well as health or mindfulness-related activities such as hiking or meditating. For example, this quote reads, "I've been feeling really good these past couple of months. I reach out to friends or hike to manage stress." Next slide, please. So when discussing mental health strengths, some participants described currently experiencing mental health problems, but stated that a strength was that these problems did not impact their day-to-day life in a debilitating way. So for example, this participant stated, "I usually feel good, I feel happy, even though my life is a mess right now." In contrast, other participants stated that a mental health strength was that they're not currently experiencing any mental health problems. These participants often described their mental health as stable or strong, and in some cases, like in this example, the participants directly identified life events that improved their mental health. So for example, this quote reads, "The participant has had suicidal ideation in the past, relating to feelings of not belonging because he was not comfortable with his sexuality and hadn't come out yet. Once he came out to his family and figured out who he was, he no longer had those thoughts." Next slide, please. Within external resilience resources, many participants discussed close social relationships as a mental health strength. These relationships were described as sources of stability, positivity, or acceptance. For example, this quote reads, "When I feel low, I can call my friend since he deals with depression too, and we can talk about it and go through it together." Finally, participants discussed engagement with mental health care resources, including therapy or counseling and medication use. Among participants who discussed mental health service utilization as a strength, accessibility, affordability, and affirmation from providers were all emphasized as critically important. One thing to note, though, is that not all participants who discussed these themes of mental health care utilization had positive experiences with therapy or medication, and therapy and medication were not described as cure-alls. So for example, this participant stated, "Having my medication is a strength. but having it not work perfectly is also a strength because it has pushed me to develop tools for my mental well-being. If Zoloft was perfect, I wouldn't have discovered the techniques in managing my depression and anxiety. Next slide, please. So these results highlight the utility of strengths-based approaches and resilience frameworks within the context of mental health promotion for youth at risk for and living with HIV. Many participants in this sample reported significant past and/or current mental health challenges, but they were still able to identify and reflect on their own mental health strengths. One limitation of this analysis is that not all participants who were offered coaching actually participated and completed a strengths assessment. And so this limits generalizability. A second limitation is the use of coaches' notes on participants' responses to the strengths assessment questions, rather than the use of something like direct transcripts. But this limitation does also highlight a potential opportunity for future studies to incorporate a greater qualitative focus to center the voices and experiences of participants outside of the context of traditional sources of qualitative data like interviews or focus groups. So while a growing body of literature emphasizes the importance of resilience and strengths-based approaches for mental health promotion among youth, we further emphasize the importance of engaging youth to identify and describe their own strengths and protective factors, because this allows for the description of factors beyond those already identified by researchers or healthcare providers. These factors, in turn, can be utilized in future interventions to better tailor mental health care to youth's needs, unique lived experiences, and their existing strengths. Thank you.
Thank you very much, Katherine. Really great presentation, and I look forward to the discussion. So the next presenters are Curtis Wong and Alice Ma, and they're going to be presenting on sexual health promotion methods and decision-making among youth at risk for and living with HIV in Los Angeles and New Orleans, a qualitative choice-based analysis. So thank you.
Hello, everyone. As Laura presented, my name is Curtis Wong, and my colleague Alice Ma and I will be presenting on sexual health promotion methods and decision-making among youth at risk for and living with HIV in Los Angeles and New Orleans, a qualitative choice-based analysis. Next slide, please. First, we have to understand that traditional risk reduction interventions in sexual health promotion studies often emphasize on adherence to a singular prevention method of the researcher's choosing and does not recognize the unique circumstances and factors that can affect a participant's preference for a particular HIV prevention method over another. For example, since the introduction of PrEP as a prevention method, there has been emphasis on the uptake and adherence of PrEP without considering the participants' preferences or lived experiences. However, some participants may choose to forego PrEP for condoms or will get regularly tested instead. A choice-based framework acknowledges that individuals may make informed decisions regarding their own health promotion decisions, and that these decisions are influenced by factors across socio-ecological levels. Simply put, their lived experiences, identity, and perceived risk and barriers impact their decision-making, especially in personal decisions such like their sexual health. Additionally, there is limited literature surrounding the choices of youth at risk for or living with HIV, and the reasoning behind these choices. There's also a lack of literature in understanding the self-determination of youth at risk for or living with HIV in their sexual health. The youth themselves may hold more agency and power than expected when they make decisions concerning their own lives. Next slide, please. As our colleague Kate presented earlier in the second presentation on mental health strengths, our participants were youth at risk for and living with HIV, ages 12 to 24, living in Los Angeles and New Orleans from 3 studies in the Adolescent HIV Medicine Trials Network. These participants were offered strengths-based coaching as an intervention, and these coaches conducted a semi-structured, open-ended strengths assessment. Coaches' notes on these strength assessment questions were analyzed and coded and deduced with a focus on sexual health promotion behaviors and decision-making. Next slide, please.
Participants describe factors influencing their sexual health decisions across 7 categories of prevention methods: PrEP use, condoms, relationships, sexual inactivity, STI testing, PEP, and ARV adherence. Our results are in line with a choice-based framework with emphasis that sexual health decision-making is complex and influenced by a variety of factors across socio-ecological levels, intrapersonal, interpersonal, and structural. Next slide, please. At the intrapersonal level, participants described their own individual perceived need for sexual health promotion methods in accordance to their own behaviors, and often the frequency of sexual activity or number of sexual partners. Participants also described individual preferences for sexual health promotion methods like condoms, PrEP, PEP, etc., as well as personal motivations to pursue sexual health promotion. We see this highlighted in the selected quote, which reads, "I don't know enough about PrEP, and I don't think the world knows enough about it either. I am not willing to ingest it every day, not knowing what it will do to me when I'm 50. I also don't trust mass pharma drugs, especially knowing of the historic targeting of queer bodies. I don't think they have our best interest at heart." Many participants also expanded on their own experiences that informed their personal motivations to pursue sexual health promotion. Next slide, please. At the interpersonal level, participants describe how their sexual or romantic relationships played a role in their sexual health decision-making. Many participants used their relationship status and style, whether they were single, monogamous, polyamorous, etc., to gauge their own needs of sexual health promotion. We see that highlighted in the quote shown here, which reads, "The participant doesn't use condoms now since he's in a relationship, but before being in a relationship states he would use condoms almost 100% of the time in addition to being on PrEP." This quote and others highlight that decisions about PrEP and other methods of sexual health promotion are influenced by perceived risk as a result of interpersonal relationships. Next slide, please. And finally, at the structural level, participants describe barriers to accessing sexual health resources like PrEP, STI testing, and sexual healthcare services, citing difficulties in affordability, accessibility, and insurance. We see that exemplified in the following quote, which reads, "I feel like if I get on PrEP, there will be a way for my mom to find out. I don't know if it's super discreet." This quote highlights structural level barriers through healthcare providers and insurance policies that often make access to PrEP and other sexual health resources and services inaccessible to young people. And if you're specifically interested in barriers to PrEP, our colleague Jasmine will be presenting a poster on barriers to PrEP initiation among at-risk youth later during the poster sessions, so be sure to check out her work. Next slide, please.
However, it is important to note some limitations of the study, such as data being taken from the coach's notes, meaning that direct quotes from the participants were limited as we did not use interview transcripts. While this means that not every interaction between the coach and participant is recorded, it does present a novel way to conduct qualitative research, as these notes often resemble case notes that is commonly available in social work and medical record systems. Furthermore, considering the importance of intersectional identities and people's lived experiences and sexual health decisions, future research can examine how these decision-making processes differ based on their identities. Moving forward, healthcare providers can emphasize the choices that are available to youth at risk or living with HIV surrounding HIV prevention. By centering patients' decisions and preferences, it could lead to meaningful decisions within patient-provider relationships, as well as improved adherence to a chosen prevention method. Individual choice is an important aspect of patient-centered care, and such approaches are especially important for ensuring that communities that are marginalized are heard and that they make informed decisions that are right for them. As discussed throughout the presentation, a choice-based framework helps researchers and healthcare providers understand the sexual health decision-making that youth at risk for or living with HIV undertake. Youth at risk for or living with HIV have a variety of factors that they consider as they make important decisions surrounding their sexual health. An individual's choice is a reflection of their lived experiences, and as researchers and healthcare providers, it requires an understanding of those lived experiences to help provide informed decisions to individuals who may not be heard at all. Thank you very much.
Thank you so much. This was really a wonderful group of presentations. And as I mentioned, please put in the chat box any questions